syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Hi, everyone. Welcome. We are gathered here to do the next live stream of TMD Demystified. I am Tony Urbanek. I certainly appreciate you being here, and this live stream is designed for patients, people, and doctors who want to learn more about TMD, temporomandibular joint disorder. It's really designed primarily for the public who would like to ask questions about this problem. I have been dealing with patients with TMD for the better part of 50 plus years, both surgically and non-surgically. For those of you who don't know me, I'm an oral and maxillofacial surgeon based in Nashville, Tennessee, actually based in Franklin, Tennessee, where I'm sitting right now on a Saturday at noon. This problem, TMD, is a very big problem, and we're going to get it solved pretty soon. For those of you who follow me, you know that I've done a lot of research on the problem itself. For the first 36 years of my career, I did surgery on the temporomandibular joint, better than 2,000 cases, half of them open joint surgery through an incision into the ear, in front of the ear and into the joint itself, and half of them through an arthroscope operating through a scope and watching what I'm doing on a television screen. But 15 years ago, I decided that this was not going to be a successful action long term, and I wanted to see if I could figure out what was really going on about temporomandibular joint, because including surgery and certainly all of the non-surgical attempts at treating this problem were generally exclusively a big failure. Treating symptoms is not the way to go. You have to learn about what causes the symptoms. What's really going on with this disease? In 2026, the academicians, the dental schools, the people that write the book are still treating symptoms. And it gets worse than that. They are calling each and every one of those symptoms by a different name, therefore they're different diseases. It's not several diseases. It is one disease caused by a single thing. And that's what I've proven. That's what we have a academic study proving that all of the disparate symptoms of TMD are created by inflammation within the joint. Therefore, if you can make the inflammation go away, the symptoms will dissipate and go away. That is what I discovered, but I really only read the literature, which was already there, and the discoveries were made by orthopedic surgeons over 70 to 100 years ago regarding what causes pain associated with inflammation in the joint, the mechanism. And the mechanism that causes temporomandibular joint disorder, one disorder, inflammation in the temporomandibular joint, is the same mechanism that causes pain in and around inflammation and damage to a hip, a knee, and an elbow. And that is just a fact, and it amazes me. It's absolutely stunning. When I took myself out of the maxillofacial arena and quit listening to what my colleagues said was the right thing to do, and the textbook said was the right thing to do, and the congresses said the right thing to do, and the articles in the journal discuss what was the right surgical approach to temporomandibular joint. When I stepped back and did the investigation, amazingly, I found that this is not really a complicated problem when you know exactly the mechanism that causes the symptoms. Now, this is a repeat for many people who follow me along. If you are new to this channel, if you are new to this live stream, I encourage you to ask questions. I want you to ask questions. I'd like you to make comments. I'd like you to learn more, because this thing that everyone in the world calls TMJ, which is an example of why they never really found a solution, because they even called the problem the name of the joint. It's like going to the orthopedic surgeon and announcing you have knees. You can call it anything you want. In my office, we just call it jaw joint problem, because I refuse to call it TMJ unless I'm actually talking about the joint itself, temporomandibular joint. The accurate name is temporomandibular joint disorder, one disorder created by inflammation in the joint, which creates the following symptoms. Very disparate symptoms: headache, earache, jaw pain, neck pain, tinnitus, which is ringing in the ears, subjective hearing loss, which is that feeling of fullness in the ears where you feel you got water in your ear and it won't go away when you haven't been swimming. Dizziness, vertigo, and dizziness generally and vertigo are defined a little differently, but I speak of them as one issue or one symptom. They're related, they're similar, but dizziness, vertigo is one of the three symptoms, triad of symptoms, that are known as Meniere's disease and examined and diagnosed by primarily otolaryngologists, ENT surgeons, is what we're going to talk about today a little bit in detail. And then upper back and shoulder pain and tightness, arm, hand, or finger tingling or numbness, and various kinds of jaw locking. And each one of those symptoms I discuss in detail in one or more of my recorded podcasts, which are published, which are recorded every Tuesday, and I believe they're published on Thursday on YouTube and Dentaltown, and if you just want to listen, on Spotify. And each one of those symptoms is discussed in detail as to how that symptom, the mechanism, the pathophysiology mechanism of that symptom is created by inflammation in the joint. So obviously, if you can make the inflammation in the temporomandibular joint go away, the symptoms go away. I'm not going to go over those mechanisms except for one today. We're going to talk about Meniere's disease. Meniere's disease, definition of Meniere's disease are the symptoms themselves. If you Google AI, or you look in the textbooks, or you ask an otolaryngologist, ENT surgeon, how you define Meniere's disease, he will say, we define Meniere's disease by the 3 symptoms associated with Meniere's disease. True statement. And again, those 3 statements, those 3 symptoms are tinnitus, which is the proper pronunciation of the word. A lot of people call it tinnitus. Tinnitus would be inflammation of the area. Itis, inflammation. Tinnitus was the ringing in the ear, subjective hearing loss, fullness in the ears, and dizziness, vertigo. That is the definition of Meniere's disease. And if you have one or more of those symptoms, you can go to an ENT surgeon. He will do a big workup, usually a very expensive workup, including an MRI. And after he does all that, he will say, well, your symptoms are consistent with, and the examination is consistent. We can't really see much on the examination, including the MRI. There's really nothing, no objective findings about these 3 symptoms. They can't see anything on X-ray. There is no lab examination that proves that where it's coming from or what it is, other than the symptoms themselves. But he will say, she will say, you have Meniere's disease. And the patient will say, thank God, this has been driving me nuts for years now. I'm glad we know what it is. What do we do about it? And the doctor will shake his head, roll his eyes, and say, we have no solution for Meniere's disease. However, we know absolutely, and anyone who sees enough patients with temporomandibular joint disorder knows that those 3 symptoms are consistent with many, not all, but many patients with temporomandibular joint disorder. More males than females, by the way. Just to remind you, temporomandibular joint disorder is a female disease. 45% of females in the United States of America have TMD symptoms, headache, earache, jaw pain, neck pain, etc. 45%. It's heavily weighted toward females, 90% females, 10% males, and almost always associated with females, 90% females, who are either highly motivated or highly stressed, which goes along with bruxism. We know that the 3 causes of damage to the temporomandibular joint, we know that there are only 3 causes, categories, if you will. Categories, we better word than cause, because each has a separate category that damages the temporomandibular joint. And the 3 categories are bruxism, which is clenching or grinding the teeth. You can do it during at night. You can do it during the day. You do not have to make noise while you're doing it. You can do it both night and day. But we know one thing about it. It is related to stress, and that goes all the way back to biblical times, where the quotes are various of people who clench or grind their teeth under times of stress. And so it's kind of floats through the literature all the way from biblical times. But bruxism is clenching or grinding. The second category is acute trauma of various kinds. It can be, there are hundreds of ways you can acutely traumatize this joint. Automobile accidents is the most common. Whiplash injuries is the most common of automobile accidents. Whiplash is extremely common. That causes temporomandibular joint damage because when the neck snaps back instantaneously, the jaw snaps open, over open, and damages the internal structures of the temporomandibular joint by the jaw going back and snapping open. But all kind of accidents. And here in Middle Tennessee, we see a lot of horse accidents. I've seen many facial and jaw injuries from horse accidents, falls off here, horses, kicked by horses, horses jumping and people falling off. And then, of course, athletic accidents. And here in Tennessee, pretty common bar fights, 4x4s off the back of the pickup truck. All kind of altercations. Boxers. I've treated many athletes who are boxers. They kind of obviously they leave themselves open for jaw joint problems later on. Fortunately, they're females and they're not so prone to develop the painful symptoms. They're more prone to develop the non-painful symptoms of TMD, which are tinnitus, subjective hearing loss, and vertigo. And they also complain of pain, but to enlighten the patients out there and the doctors, men will more likely call tightness, where the females will talk about specific pain. Men will talk more about tightness. And of course, I've had many men talk about pain, and I've had females talk about tightness. But the reason it's a female problem, again, look in the literature. If you ask your dentist, he's not going to know the answer to this question. I can promise you, if you ask your oral surgeon, the answer to this question, why is it females? Why is it 90% females? He will not know, but it's been in the literature for 70 years. In the general basic science literature on cell biology and physiology, estrogen, the female hormone, exacerbates inflammation. And because this joint is a problem of inflammation in the joint, it stands to reason that if estrogen exacerbates inflammation, it would be highly more productive and present in females. All right. I don't want to go on longer than about 30 minutes in our live stream. I usually limit to about 30 minutes. We got a couple minutes late start. I had a little technical problem on the start. Anyone who saw that, I apologize. And I'm watching any live stream viewers who'd like to ask questions or comments, and so far I haven't seen any, which is all right. We're going to go on for another 10 or maybe 15 at most minutes, and I want to discuss exactly this problem known as Meniere's disease and the confusion of Meniere's disease treated by ENT surgeons and ringing fullness dizziness treated by dentists and oral surgeons who actually figured out how to treat this non-surgically by unloading the temporomandibular joint with a very simple device that separates the posterior teeth long enough to allow the inflammation in the jaw joint, temporomandibular joint, to go down. There's a protocol that goes with this. The doctors out there, the dentists out there, you do not have to worry about super eruption of teeth. That's why the protocol is there. Super eruption, when you separate the back teeth, this device is very simple. Only the front teeth touch. 90% of the loads on the temporomandibular joint are created by the back teeth, the posterior teeth. This whole process of how I learned this and got into it and found the actual solution was actually assisted by many of my patients when I started doing the research, who told me if I put my finger, my tongue, a pencil eraser between my front teeth, it feels better. So I made a device that put something between the front teeth that they could speak with, that they could swallow with. Obviously, you can breathe with it, but you just can't chew with it in your mouth. So the protocol is very important. 24/7, 24 hours a day, 7 days a week for 2 months, then nighttime only the rest of your life. Nighttime defined as any time you sleep, including nap time. You separate the posterior teeth, and you dentists out there, for 2 months, you're not gonna have super eruption of posterior teeth. What you will have when you put someone in a device that only the posterior touches, you will see the whole mandible, the entire lower jaw, shift back a little bit to that second bite that everybody has. Everybody has two bites, centric occlusion, where your teeth mesh together well, with or without the help of an orthodontist. And bite two is where the whole jaw slips back, where the ball fits in the socket comfortably, correctly, and we call that in the profession centric relation. It is also called rest position. Why rest position? Because that's where the joint rests. That's where the jaw rests best. That's what allows the inflammation to die down, no matter how much damage is done to that joint. I have x-rays that in my prior life as a surgeon, I would have jumped on it in a heartbeat to do surgery because there was so much damage in the joint. And now we can do that little device and protocol, which is just as important as the device, and get much better results of alleviating all of the disparate symptoms. So simple. Truly simple. And again, for you dentists out there, separating somebody's back teeth for 2 months do not cause posterior super eruption, in other words, extra eruption of the posterior teeth and open bites and things like that. It will though, if you already have a functional malocclusion, a big difference between bite 1 and bite 2. You will see the mandible drop back significantly. Well, that functional malocclusion was already there before we started. And most orthodontists, I think a few out there do realize that. I know the doctor who works in our practice knows that about the 2 bites. But most orthodontists don't consider what they're doing to the joint when they're jerking around and putting traction on the jaw when they're moving teeth. Now, you can move teeth and bone without putting traction on the jaw, but a lot of orthodontists try to move teeth and put significant traction on the entire jaw, which will damage the joint by creating a functional malocclusion. That's why orthodontists, I think, need to get more education in their basic educational series. So today we're going to just talk about one thing, and that we've had a shout out from one of the primary platforms in dentistry. It's called Dentaltown. I think every dentist in the country, and maybe many of the dentists in the world, know Dentaltown is a platform that promotes and teaches doctors about every aspect of dentistry. They have really good articles. And this month's June volumes 27, issue 6, June 2026, we had a shout out, a recommendation from the editor of this magazine. It's also online, Dentaltown Online, Dentaltown Magazine, as a featured episode and a featured podcast. One of my podcasts, which I also published on Dentaltown, was featured by Dr. Howard Farron in his Dentistry Uncensored series. And I wanted to, and I take a win on that because we've been talking about this, and I was not expecting Dr. Farron to make a comment on it, but I'm pleased he did, and I want to share my screen and just read it to you briefly. This is what he recommended as a featured podcast, that whether you be a patient with one or more of these 3 symptoms, tinnitus, subjective hearing loss, vertigo, or you be a dentist who tries to see these patients and treat them, he states, after recommending my episode about the episode itself, Dr. Urbanek explores the often overlooked connection between the temporomandibular joint and the inner ear through the Petrotympanic Fissure, and we're going to discuss that again. One of my, I think I have at least two other episodes TMD Demystified, which specifically talk about the Petrotympanic fissure, but we're going to go over it briefly today before we end up. For those, I don't want to leave you hanging. Through the Petrotympanic fissure, TMD can produce symptoms that closely mirror Meniere's disease. Well, it more than mirrors Meniere's disease because the ENT doctors have no idea what causes Meniere's disease, and we know that TMD causes ringing, fullness, and dizziness. So I don't know how you can say that they're not the same disease. I don't know whether there's any difference because ENT doctors define it just on the symptoms, and we know those three symptoms are created by inflammation getting into the middle ear through the Petrotympanic fissure, a thoroughfare which allows inflammation, remember, inflammation in the temporomandibular joint, to get into the middle ear where the mechanisms are for your vestibular mechanism, which keeps you upright and balanced, and your hearing mechanism. Those are the mechanisms that are in the inner ear. So, including tinnitus, vertigo, and subjective hearing loss. This episode unpacks the clinical implications and what it means for diagnosing patients who present with both TMD pain and ear-related complaints. And many patients do have both sets of categories of symptoms, which are the non-painful, ringing, fullness, dizziness, and the painful, ringing, headache, earache, jaw pain, upper arm and shoulder pain, neck pain, arm, hand, finger tingling, and numbness. So let me carry on here a little bit more and see if I can pull up what else I wanted to show you here. There we go. And I'm going to share this with you. This is just the explanation, is what I'm talking about. This mechanism, this fissure, basically a highway that can allow inflammatory fluids and cellular exudates, inflammatory cell exudates, to go from the temporomandibular joint. Hopefully you can see my pointer. This is a slide directly out of Gray's Anatomy. My Gray's Anatomy, which was given to me by the chairman of the Department of Anatomy at Indiana University while I was working on my degree in cell biology and anatomy after I finished dental school. And he learned that I did not own a Gray's Anatomy because I couldn't afford one, and he gave me his own copy. This is from a 1954 edition of Gray's Anatomy, previously owned by the chairman of the Department of Anatomy at Indiana University. But I want to point out the Petrotympanic fissure right here. This, if you can see my pointer, hopefully you can see, this is looking at the skull from the side, from the outside. This is the ear canal. This is the bony part of the external auditory canal, bony features of it. This is the jaw joint. We call the glenoid fossa, which is the socket. We call that the glenoid fossa. I have it labeled here. Yeah, post-glenoid process. Different features. We won't go over the anatomy of the joint itself, bony features, but one of the features prominently shown on this diagram on a Gray's Anatomy textbook, which is about 4 inches thick, from 1954, and that book has not changed much in the past 70 years, Petrotympanic fissure, which was first observed and written upon by a Dr. Johann Glasser in 1680. He was a Swiss anatomist who discovered, found, described, and wrote upon the Petrotympanic fissure, which is a fissure, a highway, which can allow whatever can get through it into the middle ear. So you can see right here at the distal aspect, the posterior aspect is where that little fissure begins, and I'm going to show you where it comes out at in a moment, if I can do this correctly. Now this is another slide from that 1954 edition of Gray's Anatomy. And to orient you, whether you be a dentist or a patient, you are now standing inside a exploded view of the middle ear. So if you imagine yourself inside the middle ear, which is encased in a solid piece of bone, and that bony structure is there to protect these very, very, very precise instruments of hearing and keeping you balanced, the vestibular mechanism and the hearing mechanism. And here you can see where the opening of the Petrotympanic fissure is. And Dr. Glasser, he also put his name on that fissure. It was later, in later editions of the anatomical textbooks, it was called the Petrotympanic fissure because it connected the petrous part of the temporal bone to the tympanic part of the temporal bone. But it is a highway, a vestibule, which allows fluid to get into the middle ear. It is called the Glasserian fissure and the Petrotympanic fissure. Same fissure, two different names, identified by Dr. Glasser. Also through that fissure go a few other structures. There's a vessel that goes through there. But more importantly is a branch of the facial nerve that comes off the facial nerve within the temporal bone and is called a chorda tympani. That chorda tympani, most dentists have heard about, at least if they remember. I can't believe you ever got through dental school without hearing about the chorda tympani, knowing where it is, what it's all about, because the chorda tympani supplies taste to the anterior two-thirds of the tongue. There is some information that I'm trying to put together that will describe and may describe why burning tongue is associated with inflammatory fluids coming through this fissure. Because right now in the literature, I can promise you that burning tongue has no solution. And we're working on that particular project to see what the potential is to proving that burning tongue is also associated with chronic inflammation coming through the Petrotympanic Glasserian fissure into the chorda tympani and then perceived by the patient as burning tongue. All right, but anyway, you're standing on the middle ear, and you're standing inside the middle ear. The structures inside the hearing mechanism, the fluid within the hearing mechanism and the vestibular mechanism is what is considered the inner ear, and then the external ear is what we talked about, that from the tympanic membrane on outward, and here's the tympanic membrane inward. But that is how chronic inflammation, cellular exudates, and fluid with a very low pH, by the way. Chronic inflammation has a very low pH. That is the amount of acid, very acidic. And it is not known by me. I don't know how you can decide what the effect on the fluid is within these structures right now. It's such a fine area. However, just if it was just decrease in pH to a very acidic environment, that would be more than enough to damage the hearing mechanism and the vestibular mechanism, causing those three symptoms. So that is the story of the Petrotympanic fissure, which we have been acknowledged, and gratefully so. I am grateful to Dentaltown and the staff and the doctors who did that to give us acknowledgement today that that is a very important structure to know about, and very, very important to know about as it's related to temporomandibular joint disorder. So at this time, I'm watching the live stream viewers. I still see no comments, questions, or challenges. And I'm ready for challenges. Just be prepared if you're going to challenge, if you're going to criticize. Please bring your documentation. If you would argue with me, as Voltaire said, you must define your terms and bring your arguments with you. All right. With that said, I look forward to our next live stream, which hopefully we will be produced every noon on Saturday, usually about 30 minutes. And I leave more than enough time in an hour segment for questions, comments, and criticisms. If you are a doctor who wants to learn more about how to use this device, it is a patented device. Fortunately, we were able to acquire the patent on this device. It is actually made CAD/CAM, 3D printed now. It used to be made kind of in a dental lab, but now we're much more sophisticated. This device is made on a computer, extremely precise when it's printed, finished off by a human being, polished up by a human being, QC'd by a human being, and then sent to any of the network providers, the dentists who are now in 20 states who provide the Urbanek device and protocol. If you are interested in looking into this, if you're a patient, you can go on our website, www.urbanektmd.com, urbanektmj.com, urbanektmj.com, URBANEK, and you can see the list of doctors who are licensed to do this patented protocol and device, who can help you and do the same thing we do here in Middle Tennessee, treating thousands of people. We are now well beyond 5,000 successfully treated patients with that device and protocol of which I'm speaking. All right, until next time, I look forward to seeing you. I hope you had got something from this episode and can apply it either to yourself or to your patients. I am Tony Urbanek, and this is TMD Demystified. Oh my God.